Hi guys, welcome to chapter 27, Musculoskeletal System. Here we go. Okay, common musculoskeletal conditions. Let's talk about sprains. Well, when we talk about sprains, we usually talk about RICE, which is rest, ice, compression, and elevation. When we're talking about a sprain, it's usually what we're talking is an injury to the joint that results in muscle ligament damage. Okay, so a sprain is basically something when we do an x-ray we're not going to see anything. So if we don't see anything and it's swollen, turning purplish, and there's no bone fractures, then generally we're going to call it a sprain. Sprains sometimes actually take longer to heal than your fractures. So, if anybody says, oh, it's just a sprain, well, no, that's sprains because we're talking about ligaments, and ligaments don't have a lot of blood supply to them. You might be a little bit more laid up than if you just had a hairline fracture. Okay, next thing we're going to talk about is fractures. That's a break in the bone. Okay, hopefully the places we can place the ends close to each other. If it's, you know, if it's a compound fracture, we're going to put those ends together so they can grow back together again. Usually we look at 4 to 8 weeks for them to grow together. Sometimes though the fracture is so bad that it's going to need pins or wires, screws, um, or even an immobilizer. Depends on how bad the break is. When we're talking about a hairline fracture, we're talking about a narrow crack. When we're talking about comminuted fracture, that means that that fracture has a lot of little bones. Okay, joint replacement or arthroplasty basically remove the damaged bone surfaces and place with new metal or plastic surfaces so it doesn't hurt so much. You don't have that swelling. Um, when we think of joint replacements, we're thinking of hip, shoulder. They actually do ankle replacements, especially somebody that has a lot of arthritis. Um, but generally, we're talking about. I'll be surprised if we don't have to do finger joint replacements, because we're click, click, click on our mouses all day. I'm figuring that pointer finger is going to be one of those ones that we're going to start redoing. We're talking about advanced osteoarthritis. We're talking about degeneration, inflammation of the joints. It usually comes with age, but some people get depending on their history, they can get it a lot earlier. We generally think of anybody that had a fracture would end up with osteoarthritis in that joint or in that bone. An amputation is what we're talking about with surgical removal, and it could be for a number of things. We can do an amputation because they were in a car wreck and the bones it's just too much of a mess. We do amputations when we're talking about somebody with severe diabetes and peripheral artery disease. In those cases, sorry, I yawned. In those cases, what happens is that we cut until we can find a good blood supply. So maybe it's just the first two toes, the big toe and the second toe, that needs to be amputated. We'll probably take it either mid-foot, you know, or we can even go above the ankle, or what we would consider below the knee amputee. But amputation, we used to have a doctor, I won't tell you his name, that used to come with Good Sam. He was a locum, and every time he came, I swear to gosh, he took a body part off of somebody, whether it was leg, a finger, a foot. I think he just liked cutting. So yeah, never went to him because I was afraid I was going to lose an appendage. Okay, what do we have next? This happened to me. I was talking and I was going through my whole rigmarole, and then I looked and I wasn't recording. So I went like 6 slides before I figured I was just talking to myself. So let's see if we can't do this again. Okay, so testing for musculoskeletal conditions. We have the x-rays. We're usually looking for suspected fractures or trauma when we're looking at the x-rays. No soft bones will be, or no soft tissue is going to be We can't see soft tissue damage. We can maybe try to see it, but it ain't going to work. So then we have MRIs. With MRIs, we are looking for any kind of like pathological fracture, like there's something going on. And it's not just a regular fracture like that you fell down the stairs and you got a fracture. There's something that's causing that fracture. It could be congenital, it could be because of tumors in the bones, it could be a lot of things. So that's what we're looking with MRI. The one thing about the MRI that we have to worry about is its magnetic resonance. So what we're using is actually a big, huge magnet that's going to pull, that's going to make your pictures. Now, what's important to know is that we have to go through a whole checklist. It's like 35 questions on the MRI. Um, if you have a certain kind of pacemaker, you can't get an MRI. If you worked in a metal shop, what we'll do is we'll do an X-ray of your eyes to see if you have any metal shards in your eyes. If you have metal shards in your eyes, you can't get an MRI. If you have certain prostheses that are made out of metal, you probably will not be able to get an MRI. Okay, because what happens is that magnet pulls. And when it pulls, so if you had a pacemaker and it was made out of metal, there goes your pacemaker up to the magnet. I wonder if the heart would go with it. Don't want to check. So, we go through that. Some things that you probably wouldn't even think of. Certain tattoos, in certain times, certain years, they had metal shards in them, so they wouldn't be able to do a MRI either. So it's about 35 questions. And you're really getting down and deep when you're talking about to some of these folks. Next thing is the CT scans, and when we're looking at CT scans, we want to see a further view of the fracture, see if there's any congenital abnormalities with that fracture also. And then when we're talking about bone scans, we're talking about, we're looking for widespread bone disease, possibly metastatic cancer or bone cancer. We can also look at like osteomyelitis. We can usually see osteomyelitis on a CT scan, but we will also look on the bone scan. Okay, next. Types of embolization. When we talk about an abductor pillow, there's a picture of it in a couple slides past here. We're talking about it goes in between the hips. It looks like a wedge of cheese that we put and we strap onto the legs, the thighs. And this is to keep our patient comfortable. Usually folks that have these have any kind of hip problems, possibly a broken hip, or we just had hip surgery. We use the abductor pillows for that. Casts can be hard plaster or fiberglass. They used to all the time, if you went to the ER, they would plaster your cast right then and there. Except that what happened was sometimes they would make that cast a little bit too snug. And whenever it's snug like that, you're still having edema, and you could have a thing called compartment syndrome. What happens is it's too tight, so your body swells and there's nowhere for it to go. So then it starts going back into each other. So your nerve endings, it's going to come compress against your nerve endings, your vessels. So what we would see on a patient is maybe their fingers, if it was an arm, their fingers would turn purple. They would not have any pulse in that arm. They're going to be extreme pain. I could give somebody 20 milligrams of morphine. It's not going to help. Okay. So what would we do? Well, if I came across my patient and had a compartment syndrome, I would cut that cast off. Okay, you call the doc and get that cast off as soon as possible, because if you don't, then you're going to start amputating that limb, and you don't want to do that. Elastic bandages, you've seen them. We call them ACE wraps. Good for sprains, pulls, right? It gives them a little bit more structure to that injured area, so it can't get injured anymore. We also have the amputee compression sock. When we're talking about an amputee compression sock, after we take off the pressure dressings from a amputated limb, we would start with a shrinker sock, and that basically molds it into what the prosthesis is going to look like. Now, granted, when we're talking about this, we're talking big bones. So we're not going to put a pressure sock on somebody that lost their big toe. We're talking femur, even below the knee amputees. We can start putting that in, and it's going to make that stump um, more conducive to the prosthesis. An immobilizer, you've seen it. It's basically, I think of what immobilizer of somebody walking, you know, on their with their legs. They might have a sprain, or just, you know, maybe it's just a hairline fracture. They don't feel that they need a cast, so they'll do an immobilizer. And basically, it just stays. It protects those joints and that bone from moving and causing worse damage. We have splints, whereas the immobilizer is soft. We're talking splints, which is firm plastic molded. It's to keep the joints from flexing, moving. Sometimes we have the air splints that are used to transport patients. Um, that's for their comfort, okay? Especially if you think, we just had a friend that was in a crash, um, that both his femurs, when he was waiting for the EMTs, he was looking at his femurs coming out of his thighs. Um, they ended up putting air splints on him, just so whenever they put him in the helicopter, it just didn't. I can imagine that the tussle it would be to get in, you know, from your vehicle to the gurney, from the gurney to the helicopter. So those immobilizers helped just a little bit when we were there, when he was being transported. Okay, traction. We have skin traction. When I think of skin traction, I think of um, patients that have hip broken hips. If they're out of socket, if they dislocated their hips, what we would do is put a device around their leg, and we would put them to a pulley system, and that weight is going to pull that leg. Now, whenever somebody does have a dislocated hip, it actually makes the legs shorter. And what happens is that muscle's like, hey, this isn't where I'm supposed to be, and it'll start spasming it out. So what that does, what the traction does, is it pulls that leg straight, so it's near the place of where it should be. Those muscles should be. So hopefully it doesn't spasm on them. And we would keep them there until they have surgery. Um, we don't see much of that anymore. Usually we just take them to surgery, but you know, if there's any reason why we can't take them to surgery, or maybe the bones are really displaced, maybe it's a femur fracture and the bones are very displaced, we can put a traction on that also. When we're talking about skeletal traction, we're talking about going into the bone. So they will have pins and rods in the bone, and then to set that bone so it could heal. I had three um, pins in my pinky. I was lunging a horse, and the damn horse pulled, and I fell down. And when I stood up, my pinky was across my palm, and I thought I just dislocated, and that's what I was kind of hoping I did. Because I figured once you get it dislocated, the biggest part is getting it back into the socket. That hurts like heck. So I was kind of hoping it wasn't dislocated because I didn't want to feel that pain. But in other ways, I felt that if it was dislocated, put it back in the socket, I'm good to go, can go home. But nope, I caused a spiral fracture. So what my pinky basically did was it spun. And so I needed three pins for my pinky. I know I kind of pissed off the doctor because I was like, well, who operates on pinkies? He's like, I do. Oh, anyway, he's a nice doctor. He didn't. I just didn't. I just thought you just taped it like you did your little toe, right? Anyway, um, so the skeletal traction are those rods, and instead of like when we're talking skin traction, we just put like elastic bandage and have it pull on that. We're talking rods, and it will pull the bones into place so they can heal. Okay, caring for patients with musculoskeletal immobilization, casts. Okay, so what are we going to worry about? Well, we're going to worry about uh, neuro checks, neuro assessments when we're talking about casts. So we're going to think of the 5 Ps: pain, pallor, pulse, paresthesia, which is burning or the prickling. Some people say it's tingling or numbness, and then paralysis. That's what we're talking about. A neuro check, that's what we're going to do, the 5 Ps. You might want to know that. Um, let's see, we're going to support the patient that they're going to have casts on pillows. We're going to not touch a wet or damp cast. Okay. We're going to teach the patient not to put anything between cast and skin. A lot of times they're going to say they're itchy. So they're going to want to take a roller and start scratching it. The problem is if they scratch it and scratch something open, it could actually turn into a nice little infection. We don't want that. We're going to observe for any drainage or odors. I don't know about you, but have you ever smelled a cast, somebody having a cast in the summer? It smells horrendous. We're going to assess for the circulation, and we are going to tape petals over the edges of the cast. Okay. Immobilizers, we talked about that in the last one. We like doing that after somebody has had a cast to immobilize, give it some extra time. Let's talk about the difference between the casts. We have plaster casts, which is usually what we use whenever somebody had a fracture and they went to surgery to put that bone in alignment. It's the number one cast we would like to use whenever it's aligned. Okay. Um, then we have fiberglass casts. Usually they wear them 1 to 2 weeks after surgery. They're more durable. You get to choose what colors you want, which is the cool part. We generally use those fiberglass casts if the bone is not out of place. So if it's in the right anatomical direction, I want to say direction, alignment is a better word, we're going to use the fiberglass cast. They're better for circulation. They're lightweight compared to the plaster cast, and the X-ray can penetrate those casts, so we don't have to cut it off to see how the bone is healing. Whereas with the plaster cast, we do. There's also a thing called spica cast, which is basically on both legs. You usually see kids that have these spica casts. They might have hip dysplasia or Pert's disease. They're casts that go uh, from their hips down to their feet, and then there's a bar that goes across that puts those hips in alignment. Um, so it's kind of like the wedge that we would use, except you can't take these suckers off. Okay, they usually put them on in surgery or when the kid is, you know, I don't want to say immobile, but it's a pain for those kids. I hate when I see kids in the spica cast. They're just no fun. A friend of ours, grandson's in the goes in spica cast, and oh dear Lord, I mean we're talking 6 weeks, 6 weeks of walking like that. They could barely walk. Luckily, he's little enough that he's adapted well with it, but he screams every time they have to put a spica cast on him. So, okay, caring for patients with traction, skin traction. When we're talking about traction, we're talking about tract. We're going to look at T is for temperature, R is for ropes. We want to make sure that they're straight. A is for alignment, to make sure that limb is aligned. C is for circulation, and with circulation, we're going to do that neuro assessment, which you should know. Blink, blink, wink, wink. And then what kind of type of fracture it is. Okay. When we're talking about skeletal traction, one thing we have to worry about is the pin, where the pin site is, because that could get infected. So we're going to assess for infection. With any of these, the skin traction or skeletal traction, if you have to release the weights, you're going to do it very carefully and slowly. I'm sure you've seen comedies where they just like let go of the weight and the limb comes flying down and stuff like that. Maybe I just watched too many cartoons when I was growing up. Um, so if we would have to move the patient or anything like that, we would be very careful with that weight. With the site care, we're going to use normal saline. We can use chlorhexidine, which is the bomb diggity bomb bomb. It kills everything. Or we can use some peroxide and sterile gauze. We usually do not put any ointments on the pin care site. You can see a lot of times it dries out, but we don't want to put moisture on there because we don't want bacteria to have a heyday. Now, whenever they do have a traction, as you saw in the piece before, the picture before, they have a trapeze, what we call a trapeze, which is that triangle. And like when we have to like shift them up or anything, we have the patient hang on to that triangle so they can help us so they're not dead weight. Okay, one thing you want to make sure that those weights do not hit the floor and they do not hit the bed. Okay, they should be dangling. Okay. Okay, next we're going to talk about hip replacement, total hip replacement, arthroplasty direct interior approach. The head and the neck of the femur is removed and replaced with a titanium implant. That's one that we use the abductor pillow. With the knee replacement, um, top and bottom of the joint is replaced with titanium implants. We use the CPM machine. And what the CPM machine does, it helps with pain management, skin integrity. Um, what they basically do is the CPM is a machine that you put the knee in and it just moves it. It makes sure that it keeps with the active range of motion. Okay. Let's see. Let's think about all this. When we're talking about the knee replacement, it usually takes a couple of months for the muscles to reattach to where it needs to go, several months. Muscle and tendons not detached from the bone. Okay, if we can help it, we don't want to detach any of the muscles or ligaments from the bone because that way it's less healing time, and with that bone, with those ligaments there, it's going to be less likely for them to be dislocated again. Um, you can do a partial or a total hip replacement, depending on, you know, what needs done or what is damaged. And if you do a partial hip replacement, it's going to be shorter recovery time. Okay, I think that's it. Okay, let's go next. Okay, caring for patients with amputation. Prosthesis wound must heal properly so that a prosthesis can be placed, and it's a process. You just don't sit there and put somebody's femur in a prosthesis and say go walk. It does take a while for them. It does take physical therapy to get used to that prosthesis. We generally do not see them get a prosthesis while they're at the hospital with us. They usually go home. That stump has to be totally healed. Okay, even with that stump totally healed, changes in the patient. Maybe they gained weight, maybe they lost weight, and their prosthesis doesn't fit. What could happen is they could have bleeding and possibly infection. Um, one of the biggest things whenever it comes to amputation is the emotional support. My husband lost his pointer finger uh, due to a table saw. And you figure it's just a finger, right? Except that whenever I went to corporate events and I would drag him with me to these corporate events, he would have to do a, handshake. And we were in the city, so we had city-fied people. Here in Southern Illinois, it seemed like a big thing for everybody to lose that pointer finger. Take a look around Walmart. There's a lot of people that don't have that pointer finger. Aldi's too. And in fact, when I worked at Aldi's, I was always like, "Hey, you didn't like that finger either, huh?" And it was usually a table saw or some kind of farming accident. But he hated shaking hands with people because they would look at, we're talking city, so everybody had their 10 fingers. they would look at his finger, and he felt that they were weirded out from it. And it took one of my senior vice presidents, he asked how he was doing, and I said, he just gets weirded out, going to these business events. And he basically told them, he said for my husband to tell him to screw off. He didn't use that word, he used that F word, that it didn't matter what they felt, that he should just shake a hand just like a man, like any other man would do. That helped. But just think, that was a finger. And he was, he cut it off and went to work the next day. But it was just that emotional part. Um, Imagine if it was a leg or an arm or anything like that. You have to be there for those patients. And it's not so much you have to talk about it, like you need to talk about your feelings. It's just being in the room with him, and just knowing that you're available whenever they need to. Even people that are expecting, that they're going to be losing their limbs because they're smokers and they are PVD and they're diabetics and all that. I'm sorry, PAD, not PVD. It's an emotional roller coaster ride. A lot of people will do everything they can, once they get the diagnosis that we're going to have to amputate, so that it doesn't happen. So just be there for them. It's for the grief of losing the limb, for the embarrassment of losing the limb, that people are going to look at them funny. Just be there for them. The wrapping of the stump, it's going to heal in like a square cone shaped. We're going to have a compression sock, and they're going to always have that kind of compression sock. It's going to be over their stump. That's just to stop any kind of rubbing on the prosthesis. Let's go to the next. Okay, let's talk about ambulation. Ensure that the patient is bearing weight on their hands and their wrists. What we don't want them to do is put it on their pits. In fact, it's going to be about 3 finger lengths below their pits, or I'm sorry, their axilla, and with the tip 4 to 6 inches to the side of their heel. Okay, that's how they're going to walk with it. 3 finger breadths underneath the axilla, and then 4 to 6 inches from the side of their heel. So we don't want it too close and we don't want it too far away. Instruct the patient on how to walk upstairs and downstairs using crutches. When they're going upstairs, they're going to hold the railing on their unaffected side, and the crutches are going to be on their affected side. When they're going down, the crutches are going to be on the affected side also. Okay? Let's see what is next. Okay, assisted devices, canes. We have the single prod. We have the multi-prod, 4 tips, which is most preferred when we're talking about our elderly folks. And then we have the tripod. A cane is in the correct height with the top of it even to the patient's hip joint, as the tip positioned 4 inches away from the side of the foot, and ensure that the patient holds the cane on the unaffected side. Basically, they're going to put their full weight on that cane, but generally what we're doing is giving the extra support when they're ambulating. Remind the patients to remain erect rather than leaning over their cane. So we want them to stand straight, and ensure that the patient moves the affected leg and the cane forward together, and then moves the unaffected legs forward. I believe there's also a video underneath the crutches on how to walk with a cane. Assisted device walkers. Walkers are used by patients who can't bear full weight on both legs but need assistance to maintain balance. So when we're talking about canes, we're usually talking our little elderly people, right? They have the wheeled walker. The 2 front usually have tennis balls on them, and the back are what's wheeled. Ensure that the patient stands between the back legs of the walker. We don't want them right against the front, and we don't want them too far back. Ensure that the patient sets the walker down and steps into it. So have you ever seen somebody with a wheeled walker and they're just walking with their walker up and they're just walking without it? Yeah, don't quite understand that philosophy. Okay, ensure that the brakes are set. If they do have brakes, some don't have brakes. Instruct the patient to move the affected leg forward with the walker and then move the unaffected leg. These are for folks that can't just do the crutches. Okay, a lot of times that the wheeled walker is a lot easier for them to finagle. Okay, knee walkers, platform for the knee or the lower leg, front post with the handlebars. I'm sure you've seen it kind of looks like a scooter. It helpful for patients who cannot bear weight on their lower leg or ankle. Helps improve patients' mobility and decreases energy compared to crutches. I totally agree with that. That is so much easier to have those wheeled walkers than to walk with crutches. Clicker question. This type of immobilization device is a firm plastic mold form used to keep a joint or joints from flexing. What do you think? Did you pick splint? Yep, very good. Splints may be applied to a limb and wrapped in place with gauze or elastic bandage. Very good. Next one. What kind of device is used to accomplish flexion of the new knee joint? Prosthesis, CPM machine, cane, or Neil Walker? You're right. It is the CPM machine. The machine is designed to gently flex the patient's knee according to the number of degrees of flexion one sitting. I don't know why, guys, but CPM machines freak me out. Totally freak me out. Like, if there's a code, I need somebody to take that CPM machine and put it into the bathroom. That's how bad they freak me out. I don't know why. They look like archaic machines. Just don't dig them. So I had this one lady that she was a knee replacement. She came in for a knee replacement, ended up getting a carotid endarterectomy and a cabbage before she could get her knee replacement, but she was having a hard time breathing. We were going to get ready to intubate her, and all she wanted was chicken noodle soup. So I sat there and fed her chicken noodle soup because every time she would raise her arm, she would desat. So I did the chicken noodle soup because I knew we were going to intubate her and she wouldn't get her chicken noodle soup for a long time. But that darn CPM machine kept on looking at me, so I made sure I put that sucker in the bathroom. Problem is, when we took her downstairs to intubate her, yeah, I forgot the CPM machine, so I had to wheel it downstairs. So that's my whole theory about the CPM machines. Not a fan. Some places don't even use them anymore, but SSM still does. Okay, well, there you go. That's our wonderful lesson on musculoskeletal chapter 27. Hope you enjoyed it. Bye.